Hello, everyone, and welcome to Maximizing the Return on Your Value-Based Mission, presented by Nexera. I'm Deborah Boyer-Volk, editor of Fierce Practice Management, and I'll be moderating this webinar. Just a few technical notes before we begin. If you have trouble reading a slide, please hold and drag the right corner of the slide window to enlarge. Please also disable your pop-up blocker to participate in the interactive parts of this presentation. To download a copy of the slides, please click the Download Slide widget at the bottom of your screen. We will follow the presentations by a Q&A session. You may submit your questions during or after the presentation using the Q&A box at the right of your window. And now I'll hand it over to Leslie Eisenegger with Nexera to introduce today's speaker.
Good morning, everyone. It is my pleasure to introduce Bruce Vladeck. Bruce has been involved in healthcare delivery and healthcare policy for more than 40 years. He is perhaps best known for his tenure as administrator of the Healthcare Financing Administration during the Clinton administration, which is now known as CMS. However, he has also served as the interim president of a statewide health sciences university, as a senior vice president of a major academic medical center, and as a board member of both the nation's largest municipal hospital system, the New York City Health and Hospitals Corporation, and as the nation's largest for-profit hospital system, Ascension Health, for which he chaired the Finance Committee. In his consulting practice at Nexera, Inc., his clients have not only included academic and community hospitals, but also hospital associations, long-term care providers, foundations, labor unions, and Taft-Hartley benefit funds. A graduate of Harvard College and the University of Michigan, Vladeck has written more than 3 books and more than 100 scholarly articles. He is a member of the Institute of Medicine of the National Academy of Sciences and the New York Academy of Medicine, and has received the National Public Service Award and the Robert M. Ball Award for Distinguished Contributions to Social Insurance. So it is our privilege today to introduce Dr. Bruce Vladeck.
Good morning, everyone. It's my pleasure to be part of this webinar today and to work with our friends at Fierce Healthcare on having put it together. My assignment for this morning is to tell you a little bit more about a subject that's on the lips of everyone in the healthcare community these days, which is so-called value-based purchasing, and then to focus more, I think, on strategies by which individual institutions, particularly hospitals, can deal with this new phenomenon. So very quickly, and obviously we'll have time for your questions, and I hope my answers, or at least my responses, we'll leave a chunk of time for that before we're done. So it's really sort of a very simple outline for this morning's presentation. I want to describe what value-based purchasing is, or what it's said to be, and why you should care about it, and why everybody's sort of getting so excited about it. Then again, excuse me, I want to focus a good part of the presentation this morning on how individual institutions can best respond to the growing significance of value-based purchasing in the environment in which they operate in their lives. Take a step back from that to just sort of lay out what I've described as some kind of big picture considerations about institutional management and institutional direction in the current and coming environments. And then, again, we'll have time for questions and further discussion of the issues. So without further ado, what is this value-based purchasing everybody's talking about, and why is everybody getting so excited about it, or at least paying so much attention to it? The theory around which value-based purchasing is based is sort of comes from the following notion. Healthcare costs in the United States are too high. They're higher than they are anywhere else in the world, and at the same time, our quality performance is less than ideal, and again compares unfavorably with that in a number of other countries. The consensus in much of the policy community is that's because not so much that we're paying too much or too little for what we're buying in the healthcare system, but that we're buying the wrong things, too much of certain kinds of procedures, too little of other preventive services and things of that sort, and that we have to reorient our payment systems, redirect our payment systems to make sure that we're encouraging the purchasing of the right things and discouraging the provision of the wrong things. Or again, in the language of the Agency for Health Research and Quality, buyers should hold providers of health care accountable for both cost and quality of care. That's what's really new about value-based purchasing, is the explicit incorporation of some measure or definition of the quality of services into a determination about the payments for services. But there's another part of the theory as well, and it's the more complex, but I think in some ways more appealing aspect of the theory for many folks who are involved in the management of healthcare institutions, and why it has so much support from so many people in the healthcare community, and that is an assumption or a belief that if we can target our payment systems around rewarding good things in the provision of health care and discouraging wasteful or harmful or unnecessary services or activities or products, that will generate savings because there'll be less waste and people will be healthier, and an opportunity for both payers and providers to share in those savings in a kind of win-win relationship, even within the context of broader constraint or downward pressure on overall finances. So if we can redivide the existing pot of money in ways that don't go to stuff that's wasteful or stuff that's harmful or stuff that's unproductive, there's more to share of the residual or of the margin for both payers and providers. That is, at any rate, the theory. And the theory is, of course, often contrasted to the presumed evils of payment systems based on pure classic fee-for-service payment, in which there is an incentive for providers to provide more of any given service, whether providing more actually improves patient outcomes or not, and thus fee-for-service presumably encourages overuse of unnecessary or marginally necessary or even harmful services. The problem a little bit with this argument is that, as we'll see as we go just a little bit further through this presentation, in fact, most of the value-based purchasing mechanisms that are in place at the moment are still very much tied to the fee-for-service system, at least in a variety of mechanical ways, and we haven't yet totally gotten away from that. But we'll come back. We'll come back to that in a minute. First of all, having sort of laid out a little bit of this theory or the logic of why value-based purchasing should be good for you, why is it all of a sudden so important? There's been a lot of talk about it for a number of years. There's been some movement towards it in both government and private payers in a number of years, but I think the big headline was back this past January when HHS Secretary Sylvia Burwell made a speech in which she put very specific quantitative goals around the incorporation of value-based payment into the big government payment programs, and specifically said that by 2018, 50% of Medicare payments should be tied to alternative payment models such as accountable care organizations or bundled payments or other forms of value-based purchasing. By definition, in the Washington parlance, capitated payments to HMOs or other Medicare Advantage or other private plans are value-based payments. So, but Secretary Burwell was talking about a goal of 85% of all Medicare traditional fee-for-services programs to be tied to quality or value by 2016, and essentially all of them by 2018. In fact, that target, those goals, are a little bit less ambitious than they would appear to be. There's a little bit of sleight of hand associated with that because the Congress has already mandated, as most of you working in hospitals know, that essentially all hospitals be subject to value-based purchasing adjustments to their fee-for-service rates already, and increasingly at risk for fee-for-service payments related to their performance on so-called value-based measures over the coming years. And the so-called doc fix legislation that the Congress enacted in January to address problems with Medicare payment physicians mandates value-based payment in the Medicare physician payment system by 2018. When you account the hospitals and the physicians, you're already over two-thirds of all Medicare provider payments outside of those to manage care. And when you throw in some of the post-acute providers who are also under, where Medicare is also under congressional mandate to move to value-based purchasing, you're over that 80% target. So in a way, what the Secretary was saying was less setting out a very ambitious goal for policy as in effect reminding folks that legislation that's already on the books moves towards what is described as value-based purchasing throughout the Medicare program over a relatively short period of time in the next few years. The other thing associated with the Secretary's announcement in January was a coordinated effort to reach out to private insurers and private payers around the country and encourage them to adopt similar models or techniques of value-based purchasing. Again, I think that consisted of the Washington officials jumping on a train that was already moving, giving some of the trends that had been occurring in the private sector. But again, there is now, as a matter of formal national policy, at the most senior level, certainly of the federal government, an effort to move as much of the healthcare payment system and the financing system towards value-based purchasing as possible. So what is it that we're really talking about here? Well, the following chart, the chart that's just come up on your screens, is borrowed from the folks in New York State who, as a matter of policy, are pushing very hard on value-based purchasing, and gives a pretty good sort of summary sense of the kinds of things people are talking about. At the beginning, at the simplest level, and again, already widespread throughout Medicare and the growing number of contracts with private insurers, basically you pay the hospitals or you pay the physicians during the course of a year exactly as you would have under the previous status quo using fee-for-service payment schedules of one sort or another, but you also keep track of their performance on a variety of quality measures, whether it's the classic primary care measures of making sure kids have their immunizations or that diabetics get their A1C monitored and their annual foot exams and their annual eye exams, or some more specific kinds of outcome measures relative to, for example, the rate of hospital-acquired infections or the rate of falls occurring among hospitalized patients or things of that sort. And then through some agreed-upon, specified in advance formula, you figure out a score for that hospital or that physician or physician group more realistically for their performance during the previous year under a set of sort of predetermined rules and standards, and you then either pay a bonus associated with that, or don't pay out from a quality withhold that you've enforced during the year, or reduce the rates you're going to pay under fee-for-service for the coming year. Again, that's largely a matter of logistics and cash flow, and then you sort of go through it again with perhaps some modification of the measures, and in the case of Medicare, with some increase in the penalties and bonuses from year to year over time. The sort of second model which Medicare is using in its accountable care organization projects, and many private insurers, such as the Blue Cross quality contracts in Massachusetts and elsewhere, have used for a number of years, is that you not only measure the performance of providers, and most frequently apply to large physician group practices, for example, or to primary care medical homes, but you also determine the economic impact of their practice in terms of some measure of the total costs incurred to the insurer by their patients over the course of the year, and you have a benchmark or a goal that's total anticipated expenditures per patient over a period of time. And you get to the end of the year and you look at the actual expenditures on behalf of that practice's or that ACO's patients as compared to what you expected them would be, those expenses to be. And then if they're lower, you split the savings between the payer and the provider, again according to some predetermined formula. The next level of value-based purchasing is where the risk sharing about the costs incurred by patients who are attributable to a specific provider has a downside as well as an upside. That's the model that Medicare has employed in their so-called pioneer ACOs, with the result that about half the plans that were participating in the pioneer ACOs dropped out after the first 2 years. But it is, I think, the longer-term expectation and goal for many large provider organizations in both Medicare and in the private sector with their larger commercial customers, and I think a number of state Medicaid programs are talking about similar mechanisms as well. You really need a lot of good data, which doesn't always exist, to implement these kinds of level 2 plans. You have to know who really is using which healthcare system and have enough data about their characteristics to predict their risk of being very expensive or very cheap pretty well. But once you do, again, you can track generally over a year, but you can actually track expenditures in real time, what the total costs to the insurer are from those patients who are in some sense the responsibility of the provider or the group of provider organizations in an accountable care organization or something of that sort. And again, whatever the difference is, plus or minus at the end of the year, there's some procedure for dividing that up between the payer and the provider. And then once you've done that and learned to live with that and so on and so forth, at least as the folks in New York State envision it, you move to a system, this is the New York-specific goals, in which all patients, depending on their health status and their problems and to where they get their care, really fall into one or two categories. One category is they're fully capitated. The other category is that they have specific, particularly expensive illnesses that don't fit very well within a capitated model, but to which can also be applied what's called a bundled payment model, in which case, say, someone diagnosed with a stage 2 breast cancer, whatever provider is responsible for their care gets paid a flat amount, which is the norm or the standard for treatment of stage 2 breast cancers, and then other unrelated services for that patient continue to be paid in a kind of fee-for-service relationship. Having said all this, the fact is that if you go back to Secretary Burwell's speech, or if you look at what's actually happening, or if you look at the rate of time it takes to actually do these things and put these systems into place, we're talking about most organizations and most payers being at what the New York folks would call level 0 or level 1 for a number of years to come. And depending on how things go at that stage of the process, whether we ever get to widespread adoption of level 2 and level 3, I think is sort of an open question. And it's an open question in part because of the questions that I want to sort of very quickly describe at the moment. The big question in value-based payment is what's value, and who defines what value is. One of the things you hear increasing concern about these days, and which many of you and many of your institutions may be hearing quite a bit about, is that different payers are using different measures to determine whether an institution's or group practice or whatever is providing high-quality care or not. So if everybody is getting their payments adjusted based on their quality of care, but everyone is measuring quality of care kind of differently, it can make you quite crazy and also create a set of competing and mutually inconsistent expectations and requirements. We've known for years that, thank goodness, neither physicians nor most hospitals treat patients differently because they have different insurance status one from another once they get inside the door, and just simply keeping track of who's a patient under which quality rules and which value-based incentives is already getting to be a significant and entirely non-productive burden for many organizations. The second problem with value-based purchasing is that we don't, as a matter of policy in most places, adjust our quality measures for many of the relevant characteristics of patients, although the literature is very clear and common sense experience is very clear that some patients with a particular illness or a particular condition are much harder to take care of than others, and some patients will be more compliant with the preventive or treatment regimens that their physicians prescribe than others. And unless we have a system that takes into account those differences among patients, you can get very inequitable and sometimes flat-out weird results in a value-based payment system. Now, if you have enough patients, the basic principles of statistics and the law of large numbers say that if you have an infinite number of patients, those variations in characteristics will sort of smooth themselves out. But you need a very large number to be assured that things will come out close to the mean in every situation. And certainly with disease-specific measures, you have to be a very large hospital or an enormous group practice to have enough patients with enough cases of any given condition or any given problem to get statistically reliable measures if you don't adjust adequately for patient characteristics. Of particular concern to some institutions, particularly those in inner cities, is that among the characteristics we know affect how patients respond to healthcare treatment and medical decisions are socioeconomic status and some of the indicators of socioeconomic status, and nobody's adjusting for those in their value-based purchasing at the moment. And then it's a little bit of a concern to a lot of people that everybody talks about how we want to pay on the basis of outcomes rather than on process. We want to move from fee-for-service, paying for units, to pay for the health of the population. But since no one really knows in most instances how anything the healthcare system does is related in a quantitative or statistical sense to the overall health of the patient, there's a lot of sort of conceptual difficulties with deciding which measures are important and which should be part of a value-based purchasing arrangement, and which are interesting but not necessarily so relevant. A second problem that everybody's talking about with value-based purchasing is the question of data. I'm willing to assume or to posit that of all the people listening in on the webinar at the moment, at least 90% of you work in organizations or institutions where your IT systems are significantly better than they were 5 years ago, and at the same time performing well below expectations, or at least what people thought they would be able to accomplish at the moment. And if you take the notion of value-based purchasing very seriously in terms of the incentives it's supposed to provide to healthcare organizations and healthcare providers, then what you need is data that is not only accurate and complete and full. What you also need is data that is very timely, and that because people respond to quick feedback about their performance much more than they do about reports about what they were doing 2 years ago. But in fact, one of the major problems that the Medicare accountable care organizations have had in the biggest formal national test of accountable care organizations is that the Medicare data centers, which were used to producing data on an annual basis and under the most pressing circumstances on a quarterly basis, haven't been able to keep up with the data on what's actually happening to patients, in particular ACOs, in a timely enough way to let the ACOs really manage the care of their patients in real time, because they're always looking at data that's 3 months old or 4 months old or 6 months old, and making it very difficult to operate under those terms. Finally, there is the sort of underlying intellectual framework of whether, in fact, better quality is actually going to lower the cost. And as we begin to actually get some experimental data about the experience under value-based purchasing, we're finding that sometimes the theory works and sometimes it doesn't. And again, based on a limited number of studies, it's probably way too early to sort of generalize and say this is just not true. It almost undoubtedly is the case that it's true in some instances and not in other instances, but we're finding a growing number of instances where it doesn't work at all, that improving the quality of care for a given population with a given set of needs actually can cost you more money rather than less. And nobody wants to talk about that because that poses a serious ethical and political dilemma that certainly in the public sector people don't want to talk about at all. And then I think there's a growing suspicion, but I would say it's on the paranoid side, that what value-based purchasing is all about is an effort, and I don't want to attribute this to some deep, dark conspiracy because the people who are making this effort aren't smart enough to pull off such a conspiracy, but in a world in which payers, both public and private, have basically said, no mas, we're not paying any more money This is as much as we can afford. You're going to have to reduce what you spend, and so forth. If you think about it in a sufficiently skeptical way, this is a way to sort of sugarcoat reducing payments, or reducing at least the rate of increase in payments. And instead of saying to providers and the general public, we're going to pay you less money, keep up the good work, we're going to, instead, the payers, both public and private, are saying, we're going to continue to pay you for the stuff that's good, we're just not going to pay you for stuff that's wasteful or harmful anymore. And it's a much easier argument to sort of get away with and convince the public about, and so forth. Now, of course, that's probably too cynical a take on all these things. So having set that as background and talked about all these things, so there you are, sitting in your office or in your station or on the floor or the reception area of the healthcare organization in which you work. And in addition to everything else you already had to do, what are you supposed to do about all this? And how are you supposed to respond to this new era? Well, if there was a magic bullet on this, people more entrepreneurial than I would already have sold it to you. But I think there are 4 general rules or general principles that can be very helpful in thinking about value-based purchasing, and in defining and implementing your organization's response to value-based purchasing. And they're sort of good general rules anyway, so they're worthy of talking about and discussing more generally. Rule number 1, which can't be sort of emphasized enough or said enough. It used to be that the old saying in sort of society circles, and it was originally attributed to the heiress Gloria Vanderbilt, is that you can never be too rich or too thin. And then everybody discovered anorexia as a public health problem, and so they stopped saying that. But you certainly can never be too rich. There's never a problem of having sort of too much cash in the bank. And the fact of the matter is, neither public nor private payers are budgeting or intending that value-based purchasing will be a way you get more money. They're hopeful, and I think they really are hopeful, that if you can provide higher value and for the amount of money you're already getting and produce better outcomes with it, under their value-based payment systems, you will have better margins, you will have more cash left over at the end of the day and at the end of the year. But I think it's also true that if that doesn't turn out to be the case, even if value-based purchasing fails to produce improvements in qualities and so forth, they're not going to pay you more anyway. The political climate and the economic climate has shifted, I think, very substantially in this country over the last decade, and in a number of different ways. Both the major public and private organizations are repeating to the healthcare community, there is no more money, and that's not going to change. Whether value-based purchasing, in fact, becomes the spine around which the American healthcare system is organized over the next 10 years, or vanishes into a historical footnote to be replaced by some other rhetoric surrounding some other set of payment mechanisms, there's not going to be more money, and the pressure on healthcare organizations to produce services more efficiently per unit of service at lower economic cost per unit of service, and to eliminate services that are both unnecessary to patients and that cost more to produce than they generate in revenue, which has been around for a while. There's no question about that, but it's going to get even worse and even stronger. And the imperative to rethink how the actual daily operations of any healthcare organization work in ways to find further savings is going to only grow stronger over the coming years. As I said earlier at time, there's a whole separate issue, not only that in order to survive you have to be as tough as you can on cost now and going forward, but in a time of significant uncertainty, which we're clearly in, and which value-based purchasing is not going to reduce very significantly, there's no substitute for cash in terms of organizational flexibility, in terms of being able to focus on long-term goals and long-term plans rather than being preoccupied with short-term crises of one another and so forth. And there's another issue which we'll come back to in a few minutes, but the fact of the matter is, in effect, by instituting rules of value-based purchasing, purchasers, both public and private, are seeking to tell you not only what they're going to pay you for what you're doing, but what you should be doing, where you should be putting an emphasis on your services, which services you should be doing more of and which you should be doing fewer of, and how you should spend your money. And to the extent that you're operating very close to the financial margin, to the extent that your operating expenses fully consume your operating revenues, you are sort of stuck having to respond to their pressures. To the extent that you have your basic operating costs on a downward spiral, on the other hand, you can determine what your real priorities are, both clinically and operationally as well as financially, and focus your resources there. But you can't do that if you're teetering on the edges of costs exceeding revenues under existing or future payment systems. Before going on to the second sort of general set of rules about how to respond to value-based purchasing, as I'm sure you'll all be pleased to know, I'm sort of winding down on this presentation. My colleagues here are frantically reminding me that you can submit questions through the question box on your screen at any time during the course of this presentation, and that you're encouraged to do so, because unless people ask some questions, the last 10 minutes or so of this webinar are going to be really dull. Send in your questions. And compliments are okay, too. You can just use the question box for that if you want to talk about how enthralling the speaker is. So after that word from our sponsors, talk about sort of the second general rule of responding to value-based purchasing. And that is, we got to get over from thinking of data, particularly clinical data or patient-related data, as a utility like phone and electric power in our organizations, and recognizing that it is potentially a significant strategic asset in a variety of ways. We do tend, and I think some of this may be generational, but I think more importantly it's conceptual. We do tend to think of things having to do with IT and even with clinical records as the turf of the techies in our organizations, the people actually like sitting in front of screens, while the rest of us go about our real lives and our real business. But in fact, in a world of value-based purchasing, everyone in the organization will really have to know a lot better than they do now and understand a lot better than they do now where their costs are, which of your patients incur what costs, what your margins are and where they really come from, and how you need or you can focus your services and improve your services in ways that speak most directly and get most directly to the organization's economic well-being. Value-based purchasing quite intentionally and I think reasonably systematically changes the rules on what's profitable for a hospital or for a physician practice or for another healthcare organization and what isn't. We've been moving in that direction for several years. surgical procedures with high rates of complications or readmission rates, which used to be the bread and butter for many hospitals, are now, for example, a major source of financial risk to hospitals and so forth. And the rules will keep changing, and the character of your patients will keep changing, and the technologies will keep changing. So having close to a real-time understanding of what's really important and what isn't in terms of patient outcomes and in terms of your finances is going to be more and more complex and more data-driven all the time. And you got to get better at it. Looking at the clock and trying to speed up just a little bit, I debated at great length whether rule number 3 should be rule number 1, because what value-based purchasing is all about, certainly for hospitals and to a greater extent than they want to acknowledge for doctors as well, is getting hospitals and doctors to work together in different ways than has customarily been the practice to most effectively and efficiently provide cares for patients for whom they are mutually responsible. In the world of value-based purchasing and accountable care and other kinds of pressures, you and your medical staff will succeed, or you and your hospital, if you're a doctor, will succeed or fail together. This is going to be a particularly sensitive issue for many hospitals. It already is, because as more and more of what used to happen only in hospital inpatient services gets moved outside, whether it's surgical procedures or diagnostic procedures or imaging or things of that sort, your medical staff will be both your partners and, in some cases, your competitors, or the doctors in the community will be both potential members of your medical staff and communities. And you're going to have to figure out where the common interests are and how to develop and maintain the mechanisms to support those common interests going forward. The reassuring aspect of this, I can say to hospital people, and the opportunity that buys you a little bit of time and a little opportunity, is at the moment in many communities, not all, but many, the docs are at least as confused and scared as you are and as uncertain about what the future holds and how they're going to respond. And so when people of goodwill are involved, as they usually are, if a hospital and its medical staff can sort of sit down and try to figure out how to work together most effectively in the years ahead, there's a lot of opportunity to do some really neat stuff, I think. A well-organized medical staff with good leadership is your greatest potential ally and asset, even if it doesn't always feel that way on a day-to-day operating basis. But if people are clear about where the shared common interests are and so forth, you can really do some neat stuff, however the payment rules change over time. And finally, it's not inconsistent, I think, with the other rules, but balancing it and doing all of them simultaneously. I will acknowledge the challenge, but as a very specific aspect of current value-based purchasing measures, both in Medicare and the private sector, patient satisfaction surveys are given a significant and growing weight in the scorekeeping that's done, figuring out how much people get paid and how much they don't. I think much of the measurement that is involved with these patient surveys and measurements of patient status is pretty poor and pretty embarrassing, but that's not going to stop the payers from using these measures and continuing to reward or punish you financially on the basis of them. So it's just very important to keep your patients happy. But on a larger level as well, as the squeeze on the dollars continues, and as these become questions in both the political environment and in your negotiations with private private insurance companies, having your patients on your side is going to make a very big difference in how well you do and how many patients you have, not only in how well you do in the governmental or public policy sector, the political sector, but how you do in a world of competitive exchanges and people making annual choices about health insurance and so forth. Okay, we're low on time. The next set of slides are largely self-explanatory. Just in the to go very quickly through what I might describe as the big picture. Again, revenue growth in excess of inflation and maybe an adjustment for increase in volume of patients as no longer can be an expectation for most American healthcare providers. I think it's largely a thing of the past for a number of reasons we can talk about during questions if people want. Yet even though your revenue's going to be going down, the fact is that the expectations on you in terms of performance are going to be going up. There are new technologies. People are going to hear about that all this effort about greater transparency, about performance and everything will increase the appetite of journalists and others to do rankings and best lists and so on and so forth. And everyone diagnosing themselves on the Internet or over their phones is going to be showing up telling you about all the new super whiz-bang stuff that the FDA hasn't even approved yet, but that they need to solve all their medical problems, and you're going to have to respond to that in one way or another. And finally, just put it in the sort of broadest political terms where I come from. In most communities, not all, but in most communities, there are really three major sets of players in the healthcare system these days, or certainly in the healthcare economy these days. Obviously, the hospitals are a major part, although their share of the total pie has shrunk somewhat over recent years. The doctors are a major part in a variety of ways, and in many communities, they're much more organized than they've been in the past and much more capable of functioning in large self-governing groups of one sort or another. And then the payers, who tended historically to be a much more fragmented group. On the other hand, there is continuing consolidation and merger and similar activity in the private health insurance market. And at the same time, the share of the big public payers as a percent of all patients, all revenues of Medicare and Medicaid continues to grow. And there's actually some evidence that the government's going to try to actually get Medicare and Medicaid to work together in some ways more than they have in the past. If the payers and the hospitals come together to sort of squeeze the doctors, they're likely to be successful. If the doctors and the hospitals really can work very well together, they can dictate the terms of relationships to the payers. And some of the ACO activity we're seeing around the country, or historically in those parts of California where Kaiser Permanente was most successful, if the payers and the doctors get together, the hospitals are going to be in a disadvantaged position. They're going to be further downstream from the source of money. And all of these potential alliances depend on who commands the loyalty and respect and foot traffic of the patients, who are the common responsibility and concern of all those folks. So again, in order to succeed at all this stuff, just keep your costs as low as you can, then cut them some more. Think of data as a strategy, not as an overhead expense. Work with your doctors, cultivate your doctors, find new ways to integrate what you're doing in the doctors, and keep your patients happy. That's all you have to do to be successful in this new environment. We have time for some questions. Sorry to have left as little as I did, but let's get started.
Okay, great job, Bruce. We will move on to the Q&A, and we do have lots of great questions, and we'll get to as many as possible. Here we go. Okay, our first question asks, how does pharmacy practice figure into the equation? Where in the program? Thank you.
I think that's a very, very good question, and I think, frankly, in some of the early value-based payment efforts, most notably the Medicare accountable care organizations, it's been inadequately recognized for various bureaucratic reasons, including simple data management reasons. The total costs that Medicare looks at when trying to determine whether an ACO is beneficient or not excludes pharmacy costs under Part D because they can't merge the Part D data in a timely way with the other data. And yet when you think about managing the care cost effectively of older people, pharmacies are not only a major part of their expenditure, but a major source of bad outcomes and of excess expenditures if you don't have somebody really sort of managing it and keeping your eye on it. So some of the other kinds of arrangements we're seeing and so on and so forth are more sophisticated about that. I know in some of the so-called bundled payment stuff, particularly focusing on Medicare and other elderly patients, consulting pharmacists are really quite central to the care management teams and so forth. We're going to, I think people are increasingly going to recognize how important in the care planning and care oversight teams pharmacy is. But for both sort of bureaucratic and payment reasons, I would say many organizations have been are in the process of now figuring out how important it is, but they haven't on a widespread basis yet really integrated that into their care management, care planning kinds of activities.
Great, thank you. Next question asks, what are the key areas to focus on in the value pool for companies developing new propositions for delivering improved care in the transitional care space?
I think the critical question is going to be how either a health plan or an ACO or any other, or the central organization in a bundled care arrangement or so forth, or most typically, I guess, a hospital concerned about readmission penalties, whatever the other payment mechanisms are, how they can really evaluate the quality of care being provided to the patients they discharge, particularly patients they discharge to the community. We have a generation's worth of measurement, although, again, there are questions about the quality of the data and the timeliness of the data particularly. But at least we have a whole bunch of measurement tools associated with nursing home care and post-acute inpatient services of a variety of kinds. We're nowhere in quality measurement in in-home care. And if a key to the transition is sending a patient home with some kind of both skilled and personal care home care services during the last stage of their recuperation or first stage of their rehabilitation, it's going to be really important to whoever's at risk for those services to be able to selectively identify which providers in the community are doing a better job than others. And at the moment, that's like a total black hole.
Interesting. Thank you. Another listener asks whether you anticipate that value-based purchasing will decrease the quality of care.
I'm not too worried about that. What I'm really worried about is that it won't improve the quality of care, but sort of people will claim that it will, and will sort of skew the debate to focus on the stuff where value-based purchasing can demonstrate improvement. It's like, when I used to come home from school with A's in history and math and C in gym and behavior or whatever, and my father would focus on the C's, and all I would want to talk about is the A's. So my former colleague and the head of the Joint Commission, Mark Chasson, is one of the great pioneers of quality measurement in the United States, keeps reminding us that there are three kinds of errors in medical care. You can have overuse, which is what value-based purchasing is all about, of certain services or procedures or so on and so forth. You can have misuse, which is screwing up as your use of a particular thing. It's like surgical infections or things of that sort. But you can also have underuse. Immunizations, of course, are the classic example of that from a public health point of view. But outside of primary care, I would say 95% of the measurements associated with value-based purchasing have been targeted on overuse and eliminating misuse. And eliminating overuse and misuse are good things, and they're important. But we still have an awful lot of underuse in the system. And if anything, value-based purchasing rewards underuse. So we're getting into a world in which we'll do less of the stuff we were doing too much of, but whether we'll do more of the stuff we were doing too little of, I'm not too optimistic about. And that suggests to me that, if we're lucky, it'll be a wash in terms of the overall quality of care.
Okay, great. And we probably have time for one, maybe two more questions. Within the context of overall reduced spending, couldn't there be a shift in spending away from high-cost inpatient services to lower-cost PCP preventive services?
Well, I think there could and should be, but I think there's a misconception about preventive services and what we're now spending on them and how much benefit there is from spending stuff we haven't. I mean, if you look at the recommended preventive services from the National Clinical Preventive Services Task Force and so forth, most people get most of them. What we don't do very well in primary care is successfully identifying and managing the care of patients who are not ill at the moment but are very high risk. People with behavioral habits or genetic predispositions or other predictors, or with mild conditions that are not interfering very much with their lives, but that people think, or that where there's a risk that they will become much more severe and much more expensive. And certainly people with mild depressive episodes onto one thing, or people with borderline hypertension and borderline hyperglucose measures, but who aren't yet diabetic or aren't sick, are the other kinds of people. And those folks, the data show, really good community-based primary care with all the associated backup and other supports makes a difference over time in the health of that population. But it's not so cheap either to do really good primary care for those people, and it takes a long time. And it takes a long time till you realize the benefits of that. So if I get a high-risk patient at the moment into really good primary care in their 40s, I can significantly reduce the risk they're going to have an MI in their 50s. But it's going to cost me more than it otherwise would have cost for 20 years to produce that better outcome 20 years from now. And we're not very good at figuring out the economics of that either. So in the short term, we need to expand primary care, but we've never saved a whole lot of money by doing that in the short term. And the question is making the transition, which is necessarily going to be kind of a slow process.
Great points. And that's the last question we have time for today. We had a lot of great questions and couldn't get to them all, but we will be getting back to everyone who submitted personally after the webinar. Thank you for attending this Fierce Live webinar and submitting so many great questions. I'd like to thank our speaker today and for Nexera for presenting today's webinar. This webinar has been recorded. You will be able to access the recording within 24 hours on the same page you used to register for this event. Thank you again for joining us, and we look forward to seeing you at future events.